Good evening, and welcome back to Brookfield Public Advocate. I'm your host, Bruce Senek. As our frequent viewers already know, the show's mission statement in part reads, "We will examine issues of importance to Brookfield's residents and the surrounding communities. We will provide a venue to those underrepresented, and we will do common interest stories." Lately, Brookfield Public Advocate has been focusing on the 4-year financial crisis facing both the state and the country. We've also had many candidates on for both the U.S. Senate and for the U.S. Congress. But in tonight's show, we'll explore a topic that satisfies all three of the above criteria: important issues, underrepresented, common interest, and by anyone's standard is non-controversial and a very worthy cause: hospice. Our special guests joining us today are the Honorable Jodi Rell and Cynthia Roy Scutieri. Mrs. Rell was the 87th governor of the state of Connecticut and has been a longtime resident of Brookfield, and along with husband Lou, they both enjoy now being full-time grandparents. Ms. Roy is President and CEO of Regional Hospice and Home Care of Western Connecticut in Danbury. She entered her present role after serving as Executive Director at Mid-Fairfield Hospice in Wilton. She has previously worked with the New York City chapter of the Alzheimer's Association and the Miami Project to Cure Paralysis. Cynthia earned a master's in social work from Columbia University and a bachelor's from Boston University, and holds accreditation as both a home care manager and hospice administrator. Ladies, welcome to our show, and thank you for coming.
Thank you.
Thank you.
Cynthia, please tell our viewers what exactly is hospice, where and when and how it started.
Well, hospice started in Connecticut about 40 years ago, and it was actually Connecticut is the first state in the country that actually had hospice. And it was started because a woman named Dame Cicely Saunders, who is a physician, became a physician at the age of 34 from England, had started a hospice in London called St. Christopher's. And the purpose of that hospice was to be able to provide spiritual care and supportive care to people who were dying. And Dr. Saunders' concept was that people shouldn't be dying alone in a nursing home or an institution, and that instead that they should be surrounded by loved ones and friends in a spiritual environment. So about 40 years ago, she came to the Yale School of Nursing and she presented the concept that she was doing in London, and it caught on in the US. And actually at the time, Florence Wald, who was the Dean of Nursing, brought the concept to Connecticut, and the very first hospice in Connecticut started about 40 years ago. And since then, other hospices throughout the state have grown, nonprofit hospice. And our hospice in particular started 28 years ago. And we cover all of Western Connecticut. And hospice is a little bit different than a regular, visiting nurse service. What we do is we provide nursing care, spiritual care, chaplains, social work, emotional support and counseling, bereavement support, and all those added services. And a very key part of that is volunteers to somebody who's dying both in the home, in an assisted living, or a nursing home. So hospice is unique because we go everywhere that the patient is. And it's a really important kind of care because patients at the end of their life have a lot of issues that need to be taken care of. A lot of support needs to be offered, and hospice is there for them.
You mentioned first in Connecticut. How many hospices are there in Connecticut now?
We have 28 nonprofit hospices in the state.
Really?
Yes.
Wow. And you mentioned nonprofit. Are there then for-profit hospices?
There is. There's one for-profit hospice in the state, absolutely.
Oh, okay.
Yeah.
You've explained a little bit. Would you maybe expand a little on what some of the services that hospice provides?
Well, I think one of the things that people always know is that we provide hospice nursing. Hospice nursing is a really integral part of the care we provide because hospice nurses are unique. They specialize in pain and symptom management, which is a unique skill to have, and all of our nurses are certified in palliative care, so they have a specialty in terms of being able to know how to manage symptoms at the end of life. So that's a core part of the service. Then the other services that are offered are volunteers. Volunteers will go into the home to provide respite. So if a family is really tired and they've been caring for somebody for a long time, they need to get out to go to church, or they want to go to the grocery store, or they just want to get out to go see a movie, we have volunteers that are trained in hospice that will sit at the bedside and be there for the patient while the family member leaves and provide that respite. And that's a really important piece when families are tired and have been caregiving 24/7. They need to have that support. Yeah. The other thing our volunteers are really wonderful for is they do life review. It's often really hard for a family when mom or dad is sick to have that kind of conversation about, tell me about your childhood, or tell me about the things that were special to you growing up. And the volunteers can help transition those kinds of conversations. They can actually do life review and record things, and we have some volunteers who actually will create a book for the family member and do a photo album so that when their loved one passes away, they have that as a gift to give them. So the volunteers are pretty integral. The other thing that we do is we provide bereavement support when somebody has died. So one of the core missions of hospice is that we provide bereavement support as long as somebody needs it and as much as they need, and that's free of charge. So we have lots of families that will come to us for one-on-one counseling, group work, support groups for 12 months, 16 months, 24 months, as long as they need the support after their loved one has passed away.
Now, you mentioned free of charge, so I'd like to talk a little bit about funding. Where does funding for hospice, and I don't know if it's generally the same or if your situation is a little different, but where does the funding come from?
Most people don't know that under the Medicare benefit, there's actually a hospice benefit. And the hospice benefit is unique because it allows for medications are covered under that benefit. People don't know that exists. And that's an all-inclusive benefit. So once you elect to go on the hospice program, and your physician is certified you're appropriate for the program, you can be on the program for 6 months. And if you, under Medicare guidelines, and if you've are a Medicare recipient and you've paid into Medicare, you've already paid for our care. We don't charge anything for hospice services. So we come in as much as a family needs support they need to have, we provide it. And there's no cost to them.
Oh, that's terrific. During this last 4 years with this economic meltdown, has that hurt your funding, had an impact on your funding?
It hasn't impacted our donations as much as, lots of families will say, well, in lieu of sending, flowers, send a donation to the organization. We have seen a decrease in some of those amounts. They used to be larger, they're a little bit smaller. But still many families choose to do that avenue. What we have seen, of course, with the new health care reform is a concern about where our reimbursement will come from. Home health, which is the palliative care portion of what we do, because we also provide palliative care for patients who aren't on hospice, who aren't ready for that transition. They're actively seeking treatment for their disease. That particular program is also Medicare funded and private insurance funds it as well. But we are going to see a significant decrease in that reimbursement. And surely hospice reimbursement will follow that. I'm sure the reimbursement will be cut as well. Home health is going to be cut at least 6% in the next 4 years.
And this comes mainly from the federal government then? Does Connecticut kick in any?
No, it's a federal guideline.
Solely federal, okay. When you mentioned before about qualifying, when should people bring hospice in? And also as a follow-up, is it only for cancer patients or those that are within days of dying?
The unfortunate thing about our state is that we are the last state in the country in terms of length of stay on hospice. We are very last. Every other state in the country has a longer length of stay on hospice than we do. Our national average for hospice, the length of time somebody is on it, is 71 days. And that's unfortunate because technically your Medicare benefit is 180 days. So most families throughout the U.S. are not using it soon enough for care. In the state of Connecticut, our average length of stay on hospice is only 48 days. And that's a really short amount of time to get all these services provided to them under their Medicare benefit in that length of time. So families are coming to us very sick, in need of a lot of support, emotional support, chaplain work, spiritual care, and they're getting that. They have such a short length of time on our program, and you'd be amazed how many families say to us, oh, I wish I knew about it 3 months ago, or I wish 6 months ago someone had told me about your service because we could have used it months ago when we were exhausted, but now we're really exhausted. So that's unfortunate because people really could use our services months and months in advance, and Unfortunately, people are afraid sometimes to use it because the H word is sometimes scary for people to use to say they're going on hospice. But what you find is that once they've made that decision and they go on the program, they are so glad that they did because the support they get is pretty amazing. And the other piece about that too is that the research has shown that patients actually improve when they go on hospice. They did a whole article in JAMA about this, and the length of stay for patients, although it's short, they improve and they actually have better quality of life because they have more support in the home and more support for the family.
So when improving, then they recover in effect?
They don't recover, but they have, their medications are there for them to provide better quality of symptoms. So perhaps they were much more symptomatic, and when we come in, we tend to be able to get the symptoms under control fairly quickly, so they feel better. They may have not wanted to go out of the house for a month, and now for the first time they want to go for a ride in the car, or they want to feel, they want to get out for a little visit. So that we see a marked improvement in that issue. The other thing I think it's important is many people think the hospice is just for cancer patients, and it's not. In fact, less than 30% of the patients on our program actually have cancer. Most of our patients have Alzheimer's disease and dementias, cardiac disease, end-stage lung disease, things that are really symptomatic that need a lot of medication changes and titration so that patients are comfortable. So it's very few of our patients on the hospice program have cancer because many of our patients are living longer and better with the new cancer treatments that are available to them. Of course, we do still take care of patients with cancer, but it's becoming less and less.
Yeah. 28 in the state. Now, it's 28 hospices, but they're not all residents.
Right.
Why do you think we need a hospice residence in Western Connecticut?
So of the 28 hospices in the state, we are all independents. We're not part of one large hospice entity. I think people sometimes think we're there's one big hospice and we're all chapters of that. We're not that. We look similar in some ways because we're all Medicare certified, and when you're Medicare certified and we're also licensed by the Department of Public Health, you look similar in your program, although every hospice has its own unique uniqueness to it. Of the 28 hospices in the state, only 3 of us are standalone hospice, which means that all we do is we take care of patients who are very, very ill and who are dying. We don't take care of patients who need visiting nurse service, like for a hip replacement or a knee replacement. We don't do that kind of care. We feel it's important for us to just specialize only in end of life and have for 28 years. So for our patients, one of the things we have noticed over the last 28 years is that there is no place to send patients when they need end-of-life care outside of their home. And what I mean by that is certainly, home is the best setting. We want patients to be in their home when they die, and that's everybody's wish. But for an elderly spouse, that may not be an option if they're fragile. For a child on our program, because of course hospice is for all ages, we take care of lots of children on our program. Today we have an 11-year-old. That may not be the best option because, he has siblings in the home that are younger. He has a 2-year-old and a 4-year-old. So for that family, it's a very traumatic loss. And to have him in the home setting is very difficult. So we don't have any place to send a child like that or an elderly patient. We have a nursing home contracts. We can do hospice in nursing homes, but that wouldn't be appropriate for an 11-year-old. Or we have the home setting, and that's it. So for the very first time in 28 years, our board of directors and our staff, and we have done a whole feasibility to determine whether or not we could build actually a hospice house, a building where patients can come that feels very tranquil and is a home-like setting for them to come to that doesn't feel like an institution or a medical facility. So we are undertaking the goal of breaking ground on a building in the spring that will be in Danbury on the Ridgefield border. That will be a 30,000 square foot building which will have 12 patient suites so that families can come and stay within the room with the patient when they're dying.
Oh, that sounds very nice.